Good morning, everyone. A little feedback there. I was referring to the microphones, but thank you for that. And I also want to thank Mike and Barb for inviting me once again to this conference. And I want to assure the so-called students, I feel somewhat strange in calling people whose academic achievements are the equal of many of us in the room, but nonetheless, I want to assure the students that this program is just phenomenal, and the amount of information you can take back should stand you in good stead as you work on development of therapies. My name's Jim Cloyd. I'm a pharmacist and a clinical pharmacologist at the University of Minnesota College of Pharmacy. My baccalaureate degree in pharmacy was at Purdue. Then I went on to get a PharmD degree with a residency at the University of Kentucky. I took a job at the University of Minnesota as a faculty member in 1976, and I haven't moved. My area of interest has been translational and clinical pharmacology with a good deal of drug development. And for the purposes of this presentation, one of the highlights of my career was I and a colleague, a pediatric neurologist, developed rectal diazepam that subsequently became an approved drug for the treatment of seizure clusters. It's also an orphan drug, and because of that, I am fortunate enough to also occupy the position of director for the Center of Orphan Drug Research. And in that capacity, I've done a fair amount of work in terms of investigator-initiated and funded research from pharma and NIH regarding formulations. Marina's done a fabulous job of talking about the many complex issues related to formulations and determining then a route to use that formulation, or conversely, having decided on a route, then figuring out what formulation are intricately linked. And so there'll be some intentional overlap in this presentation with what you heard just a moment ago. So what I hope to accomplish today is to discuss the key factors in terms of delivery of drugs to the central nervous system. I'm going to really focus on alternative routes of drug administration. And then Marina's also nicely covered where you can get guidance, so I won't spend much time on that because it's already available to you. Now, let's see. There we go. And let's just see what we got here.
Just the arrow key would.
This key right here?
Yeah.
Or?
Yeah.
Yeah. Okay. So most of you, from what we've learned in the last day and speaking with you, the students, is that you were here right now, or close to it. And it may seem overwhelming, but I can assure you that it is possible at the end of the effort to get to a point where you can either have a developed product or you can hand something over, some development, to an organization like a company that can then proceed to commercialize the product. It is possible. And I don't know if Mike has said this yet. He did last year, so I'm reminding everyone that if you can't be an expert in all of these areas. And so the key is to ask questions as you go along and as you either anticipate problems or you encounter one and you need guidance. So in order to solve this equation, you need the right drug. So you need to have gotten to the point where you have some evidence of efficacy and safety. You then need to figure out the dose and the dosing regimen. And then you need to know something about the ideal formulation that matches the clinical need. That's important. And then, having done that, also look at routes, again, matching what the clinical need and indication might be. You've already seen this slide, and I won't cover it in any greater detail other than to say, as you move along the development pathway, the complexity of the formulation can increase, and there's greater regulatory requirements. What I did want to emphasize is this. Yesterday you saw that there was a slide showing the process of drug development where at some point you've learned something, you put what you've learned back into your procedure, your development plan, and you modify. And it's entirely possible that you will get to a point in your either late-stage translational work or early-stage clinical research where you see, you get some information that says you either need to change the formulation or you need to look at an alternative route of administration. So don't be surprised by that. Now, first, I'm going to speak very briefly about anatomy and physiology. Much of this has already been covered, but a couple of key points. And one of them is Fick's law. And Fick's law has to do with the rate of diffusion across a membrane. And aside from the molecule, which we've discussed, there are a couple of other important factors, and I've highlighted them. One is surface area, and I hope it's obvious to everybody that in terms of your drug delivery options, the greater the surface area, the better the absorption is going to be in general. There's also another factor here, and that's the concentration gradient. And that simply means the concentration where you have the drug and the concentration where you want the drug to go. One of the factors that goes into that is blood flow. So if you have a drug that's in intramuscular tissue or subcutaneous tissue or even interosseous tissue, for example, there you have high concentration where the drug has been deposited, and depending on the blood flow, you may not have very much of a concentration gradient. The higher the flow, the faster the drug is moved, therefore the faster the permeation or diffusion. Keep surface area in mind. We're going to come back to that. Now, this slide illustrates the potential absorptive surface area for various organ systems. And if you haven't thought about that, we've commented on how large the absorptive surface area of the brain is, and it is quite large. But look at the lung. It offers an even greater absorptive surface area, and that can be utilized in the case of drug delivery. Then you go down to GI tract, brain we've already mentioned, and then you drop down by 1 log unit to surface areas such as intranasal, buccal, rectal, and interestingly enough, intramuscular and subcutaneous, depending upon how large an area the drug injection spreads in that tissue is relatively small and hence relates to certain limitations, some of which you've already heard. You've already heard a good deal about the blood-brain barrier, so I'm not going to belabor that, but I will now go on to talk about physicochemical properties that relate to drug delivery. And I'm going to use an area where I've had some involvement, and that's benzodiazepines. You know now that the better the lipid solubility in general, this equates to faster drug permeation or diffusion, which is an advantage under certain clinical conditions. There is a price you pay, and you've heard about that. The higher the lipid solubility, in general, the lower the water solubility. So there is a tension between those two, but it can be solved. Now, the example I want to show you is in the case of benzodiazepines. And here I have 3 of them: diazepam, midazolam, and lorazepam. And I have a measure of lipid solubility here called the octanol buffer, sometimes water, ratio, the partition of the two. The larger that number, the more lipid soluble the compound is. Diazepam is pretty lipid soluble. Lorazepam, far less so. But look at midazolam. It's a very interesting compound because in its commercial formulations, liquid formulations, both injectable and syrup, it's buffered to a pH of about 3 to 4. And that's done to ionize the molecule so that it goes into solution, and therefore, Versed or midazolam is called the water-soluble benzodiazepine. And that's a very handy, please.
34 is water-soluble?
Yeah. It's highly water-soluble under that partition. If you inject or swallow, the body will almost instantaneously close that ring, creating a highly lipid-soluble substance, which very rapidly permeates into the central nervous system. And this can be shown by some work done by Arndt. This was done in cats, but what he did was inject these 3 compounds into the cat and then looked at the onset of EEG changes which he acquired through implantable electrodes. And there are two pieces of information here. One is the onset of slow wave activity, an indication of drug permeation into the central nervous system. Which one is fastest? You don't have to answer. Which one is second fastest? And which one is third fastest? And they align beautifully with the lipid solubility of the three drugs. But now let's take a look at duration of this EEG activity, and what happens? It's reversed. And the reason it's reversed, and I want to make this clear, following IV injection is the payload of the drug. A large fraction of it gets to the brain in initial circulation. It accumulates there, you exert its effect, but then the more lipid-soluble molecules are redistributing where? Fat and muscle tissue. And the lorazepam persists for a longer period of time. And that has translated into its very prominent use in the emergency department for status epilepticus on the perception it confers longer duration of action, and may well. Now, we did a study a few years ago as part of a large NIH-funded status epilepticus trial in which we took a look at what drugs were given prior to participation in the study. The study was to look at second-line status epilepticus drugs, phenytoin, valproic acid, and levetiracetam. So we collected data on what drugs did you get prior to enrollment in the study, including what drugs were administered in the emergency department. And we found a surprisingly large number of patients getting IM lorazepam in the emergency department. What do you think is the rate of absorption of the drug and its entry into the brain if you give the drug IM? It's poor. So one of the lessons we learned there is that there's a lot of education that needs to be done to make sure we're using the right drug at the right time by the right route. We have covered formulations thanks to Dr. Donovan. So now it's routes of administration. What are our options? Well, you've already heard about IV, oral, and to some extent IM and sub-Q, but there's also opportunities to deliver the drug intracerebroventricularly. There are programmable pumps that you can use for intrathecal, sub-Q, and IV. And then, as you've heard, there are technologies in which you fuse your drug to some large molecule, and I think somebody used the word warhead. The warhead then gets delivered through transcytosis. So I wanted to just spend a moment on these, what I'm going to call unconventional routes of injectable drug therapy. And the first one is the intrathecal route, and someone was mentioning the discomfort that's associated with single intrathecal injections. True. But you can overcome that if there's a reason to give the drug on a chronic basis where the target is the spinal cord or the brain, and where it's chronic therapy. So this shows a baclofen pump technology in which you have a reservoir that's implanted. You have a catheter that winds its way up to a certain level in the spinal column, and then you set the pump to deliver the drug at a certain rate. And these stay implanted for years. They need to be refilled periodically, but it doesn't require necessarily invasion into the spinal column. You can also find pumps for other types of drugs intravenously, morphine and insulin. So as you're thinking about the compound you're developing and it's the indication for it, potential use could be a pump that produces a constant or even variable rate of drug delivery, and for months at a time. Even more interesting is that there's now an approved drug where it is administered into the one of the central nervous system ventricles. This is Brineura, and it's for a CLN2 rare disease, and it works quite well. But here are some. I've listed the limitations, and I want to make clear to you that this is in a situation where there really are no other therapies. The disease is a terrible disease, and so both patients, often children, and their families are highly motivated to undergo this sort of a treatment. And it does, I've underlined here that it involves biweekly appointments to administer the drug. Yes? It's a port, yes, thank you. And so it's a manual injection into the ventricle using this port. Even more interesting, back to this notion of direct delivery to the brain with a pump, is some work being done by Dan Abrams and others in his company. They hypothesized that there are, and this is used in refractory epilepsy, they hypothesized that if you could concentrate the drug at the target organ, the brain, you could reduce the exposure elsewhere. So you could get very high levels in the brain with much, much lower exposure systemically. And so they devised a system in which they have a pump, an indwelling catheter that goes up to a port that leads into an area of the brain, in this case, intercerebral ventricular area. And they then carried out a phase 2B study asking the question, in highly refractory patients, did it help? And they used the drug valproic acid. And what they did, and here you see the seizure control as a function of drug administration in 2 individual patients. And this has already been published. And it produced almost virtually complete seizure control, which is really unusual in patients who have been treated with 3 or 4 or 5 anti-seizure medications, optimized, and still having seizures. So this is a very attractive option. And you can see then what happens. At this point, the catheter was explanted for some reason, it wasn't stipulated why, and you can see the immediate drop in seizure control, indicating that indeed this seems to be a highly efficacious approach to treating severe refractory seizures. So these are very novel. They're not for everyone, but as you consider what your indication might be and the severity of the problem, these may be alternatives. You've also heard about these complex formulations, and I'm not going to go into detail, but there are a number of these fusion technologies that are now under development. And for various conditions, these are mostly lysosomal diseases. In fact, I think they're all lysosomal disorders. Again, conditions that have a very significant impact on both health and quality of life, and for which there are very few good therapies that improve the central nervous system component of these disorders. Now we're going to switch gears. What I've talked to you about previously is the circumstances in which you might deliver your product, your drug, under chronic conditions. And now we're going to look at more likely acute scenarios where you need to deliver your drug to produce an immediate effect and perhaps with a single dose. And what are the options? Well, sub-Q and rectal. Sub-Q auto-injectors. It's supposed to be IM and sub-Q there, so you don't have an auto-injector for rectal. But rectal is a route of administration. It can be considered buccal, intranasal, and I'm going to spend a few minutes talking about interpulmonary when I'm going to ask you to go back and ask yourself, what's the surface area of the lung? So let's go back to the benzodiazepines. Midazolam has been around for 30 years or so. It's been used in the treatment of seizure emergencies, particularly status, for a very long time. And among the commonly used benzos where the injection is IM, it has an extraordinarily rapid onset of effect because even though it's water-soluble initially, it's converted to this highly lipid-soluble substance and quickly permeates to the capillaries and then to the brain. So what you have here, in this work by Jawad et al., is spike counts, not seizures, but spike counts. But it's a measure of the pharmacologic activity of the drug. And whether it's IV diazepam or IM midazolam, can you separate out the onset of effect between the two routes and the two drugs? No. Amazing. IM midazolam has an almost the same, if not the same, onset of effect and degree of effect as IV diazepam. That shows you its potential here. Now, about 10 years ago, Rob Silbergleit and others carried out a study called Rampart. And in this study, they asked the question, if emergency medical technicians are treating a patient for status, which one is better, IV lorazepam or IM midazolam? Why even ask the question? Well, as background, the Department of Defense was very interested in knowing about IM midazolam because there was evidence to suggest it might be a very good method of treating nerve agent-induced seizures on the battlefield, where you might not be able to establish an IV line. But here's what they found. By the way, if you were betting, you would bet IV. It's faster. So this was a non-inferiority trial, and the response rate for the autoinjector was 73%, whereas for IV lorazepam, it was 63%. IM midazolam was actually better. Oh, wait a minute. Look at the bottom. It turns out the most skilled emergency medical technicians in the country, because these were all very well-established ED, emergency service hubs, couldn't establish an IV line in 10% of the subjects. Is that an anomaly? When I give lectures to ED nurses, it's not an anomaly. And so it turns out that if you can't access the route, it doesn't do any good to have that formulation. But IM midazolam, because of its fast onset and its potency, was more effective than IV. And now the FDA has approved two products. One is a manual administration of midazolam, IM, and just recently the FDA approved a product that has an auto-injector. As far as I can tell, it's not yet available in the United States. Yes?
So I have a question about this emergency situation where you're giving an IM injection. Do you need to worry about clothing being in the way in terms of administering the drug correctly?
If it's a manual administration, the answer is yes. In Minnesota, this is a big problem. You've got to take off the heavy coat and the ski pants. But yeah, in general, you should, if it's manual, you should try to open up the space. And it does matter what tissue area you're selecting. So if you are picking an area of your body where there's a lot of adequate tissue, you may not be getting to the muscle. So keep that in mind as you think about that. With the auto-injectors, many of them have been set up so you can administer through a shirt or thin layered pants or something like that.
So even if you're going for like a light muscle or something.
Yeah. There may be people in the room know the auto-injector is manufactured by an Israeli company, Rafa, and as far as I could tell, it's not yet available in the U.S. Does anybody else know this story? So I don't know what the background is. It may be that it'll first be allocated to the Department of Defense for use in frontline situations. Rectal diazepam. Now, let me assure you that your patients will not raise their hand and say, please give me a rectal formulation. But when we developed this, we were actually quite surprised to learn two things. One, it's really effective. So this is a double-blind, placebo-controlled trial given the drug to eligible individuals, including adults, who had a predictable pattern of seizure clusters. And as soon as the caregiver, parent usually, or spouse, recognized the pattern, they got either placebo or the active drug, which is rectal diazepam. Look at the separation between the placebo and the active drug. Rectal drug worked about 70% of the time. The placebo only worked about 20% of the time. That's really remarkable, as I'm sure you all can appreciate. And it has a fairly good onset, but not great onset of action. So this became a product. What about buccal delivery? That can also be an option for you as you think about the circumstances under which you want to have this drug used. And in fact, a company, Aquestive, has now FDA approval for a buccal product. It's a film, a soluble film, placed on the inner cheek of the buccal cavity, and it's called Liberant. It's been approved, and apparently there is some delay in getting it marketed. And there may be other people in the room that have a better understanding of why that is. But buccal is an option. And in terms of its performance, it looks a lot like rectal might look for diazepam. It may be that it would look different if you used a different product. But buccal is an option.
Sorry, I have another question
Sure.
about delivery. So is this the sort of thing where as long as it's sort of in your mouth, it's good enough? Like if you're having a non-skilled person give this film?
The answer to that question is it depends on the drug. So this was diazepam. You place it as a film, which adheres to the cheek. So ideally, it should stay where it is. And then the mode ideally is that the molecules then get absorbed across the epithelial tissue into the capillaries. Some probably are swallowed. If you had something floating around, and for example, midazolam is given buccally, you use the oral solution, you draw up the amount, you have the patient lean over, and you instill into the buccal cavity. I can assure you that a large quantity of that is swallowed. The first pass effect, both the intestinal degradation and the liver clearance of midazolam is high. So if you gave a 10 milligram dose of buccal midazolam, you're probably delivering less than 50% of that dose, maybe even lower, to the patient, using the technology of pulling up a solution and dripping it into the buccal cavity. Now we get to nasal drug administration, and it's an attractive option for a couple of reasons, which I will explain here in a minute. And you have to appreciate a little bit about the nasal anatomy. So drug enters here, and under most circumstances, you end up delivering it into the sinus cavities in the areas called the respiratory mucosa, which then delivers the drug systemically. If you have the right technology, the right formulation, and proper positioning of the patient, you can deliver the drug to the olfactory mucosa, which potentially will allow direct delivery to the brain. And you've heard about this already. It's an intriguing notion. There is some evidence to think that it can occur. And I'm going to defer to Maureen when these questions come up, should they come up. There are lots of limitations. Limited surface area, the amount of fluid you can put in each nostril is quite limited, said to be about 100 microliters in each nostril. You could repeat after a few minutes re-administration. The drug doesn't stay around very long, either because it's absorbed or because it's being propelled backward into the esophagus and therefore swallowed. And by the way, for those who have been administering the midazolam, particularly the commercial products like the IV solution nasally, you're putting a pH of 3 to 4 in your nasal cavity. That may be okay the first time, but we have patients that are using this 3 or 4 times a week, and I can assure you that it becomes, I know personally, that it can become quite uncomfortable because we've tried some experiments looking at this. But there's a lot of interest in this area of direct nose to brain. One example, and I want to say this in rodents, and we've talked about the differences in various animals and humans. Rodents and dogs have huge nasal surface areas. And you can kind of control their positioning. So This is carbamazepine administered intranasally. It was a investigational formulation, and this peak up here is the brain concentration measured simultaneously with the plasma concentration following a nasal dose, suggestive that the brain concentrations are higher and getting there faster than a systemic circulation would allow. So this is a promising alternative. I can tell you that we've done some studies in humans in which we've tried to look at nasal versus IV for some benzos, and we've had them connected to EEGs to see if we could see the difference in onset of effect. So far, no luck. But there are people that are interested in this. So delivery is important. It depends on the compound, the formulation, and importantly, where you get that spray, in what area of the brain. Now, aside from brain, nose-to-brain delivery, the use of nasal therapies can be very attractive for acute situations. And you know, we all know about naloxone. Just last week, the FDA approved a migraine product to be given nasally for acute interruption of the headache. And this is some work done by Lahat. And what he did is he had children with febrile seizures come in, and they were assigned either to IV diazepam at a decent dose or intranasal midazolam. And the outcome measure was how long did it take to cause seizure cessation at the time the physician ordered treatment. That's when the clock started. So in one case, the nurse pulls up the solution and sprays it into the nose. And in the other case, the nurse pulls out the vial of diazepam, puts the needle and syringe together, draws out the right dose, somebody checks it, they then attach it to the indwelling catheter and push it in at the prescribed rate. So both drugs get to the same point, but interestingly, intranasal midazolam got there faster, as shown here in terms of the response rates, one at 6 minutes and one at 8 minutes. So out of that work, we now have two approved products. One is Nasalam, now marketed by UCB, and they have done some studies to take a look at the kinetics, both in healthy volunteers and patients. And as you can see, the median Tmax is 10 to 12 minutes. I want to also make a point about Tmax. Tmax is different from the time of onset of effect. Onset of effect is determined when you get enough drug to the site of action to exert its pharmacologic activity. And that's very often earlier. So if you can find out what your minimum effective concentration is, and particularly for these drugs that have very rapid equilibration into the brain, that'll give you some idea of its true time of onset of effect. And these drugs have some CNS side effects. This is an example where patients were healthy volunteers actually were examined to see how sleepy they got and when they recovered. And as a general rule, they do get sleepy, not surprisingly, but they recover in about 3 to 4 hours so they could actually return to activities of daily living. That's Nasalam. There is also, did I miss the Valtoco? Yeah, I guess I did. There's a similar product for diazepam, and it has a similar level of activity, very good bioavailability. And then this is another example where you might use gene therapy, in this case to deliver gene editing technology. And I won't go into that because it's been covered. Now, my last portion of this presentation is intrapulmonary drug delivery. And I think you'll find this interesting. So this is a technology that was developed at a different company, not Engage, which now has been bought by UCB, but they developed this technology called staccato. And they rationalized that if they had a drug that they could use with this device, they could treat anxiety acutely. And so they picked alprazolam, because it's indicated for that purpose, and it had the physical chemical properties such that they could layer an electric plate in the device with the powder. And then on exhalation, the device is actuated, the plate heats up, it vaporizes the powder, and then you inhale it. Now, not every drug is stable under those conditions, so you have to be careful about that. But let me just show you how this translates. You may have missed it. This is the process by which the device is actuated and drug is delivered. Okay, now how does this translate into pharmacokinetics? Here you have 3 different doses of the drug, and these are concentration time curves with a Tmax of 2 minutes. And these are EEG tracings that show you that once the drug is delivered, you get a very rapid response. Remember a minute ago when I told you about how you calculate time to administer a drug? I can assure you that if the choice of, or if you were calculating that time and the order was give drug now, and you had this device and you got a Tmax of 2 minutes, you're equaling or surpassing the time to hit your optimal concentrations IV, even with an IV push. It's a very interesting technology. Delivering drug to the brain is not a trivial development process, and it is, there are a lot of regulatory concerns that have to be overcome. But Jackie French and her group published recently a study in which they did in a phase 2b study with patients with predictable seizure episodes, the choice of either different doses of alprazolam versus nothing, placebo, and their response rate in this group was significantly better than if placebo alone. Now, you might ask why the placebo would have any response rate whatsoever. These are predictable patterns. Seizures typically don't last forever, so it was not surprising that in getting placebo, a number of patients are going to stop their seizures within a few minutes to a little longer. And this product is now being evaluated in phase 3 trials. So, in summary, as you've heard already, there is no universal rule for either formulations or route of administration, and it'll depend on a couple of things. Physical-chemical properties, its PK, and think about the indication. And in fact, you should be thinking about that ultimate clinical use very early on in development, because that'll drive a lot of decisions about the nature of the formulation and the route. You've already heard that keep it simple. That was the KISS symbol up there. You need to be careful about the early solvents you use. You try to avoid ones that have pharmacologic activity and that are generally recognized as safe. That's what GRAS means. And we can't emphasize enough that for almost all of you, this area of drug development is probably outside of your expertise, so get help. And you've already seen where that help can come. And when the drug development gods are with you, you move from here to a point where you have a product that you can either go on to clinical development or to then be, do a tech transfer to a company that can do that for you. Thank you very much.
Questions?
Hi, thank you. My question is about the AAV or viral gene therapy. Can you deliver through nasal method?
One of the challenges of advancing to my age in my career is sometimes difficulty in hearing. So Mike, maybe you can repeat the question?
Viral vector gene therapies, could they be administered intranasally?
That is my understanding. I presented a study in, I think it was mouse or mice, where that was done successfully. Does anyone know, has anything gone on in terms of human studies?
Gene says no.
Okay.
Other questions for Dr. Cloyd? Okay, if not, we'll retire to the outside.